afternoon. Our topic is natural transfers and mini IVF. Thanks for joining us today. We have a lot of great information to share with you. My name is Dr. Carmone. I've got Dr. Frederelli and Dr. Goulet here as well. And so I guess we should just start out by talking about some of the definitions of these things we just mentioned. So what is a natural transfer? What does that process involve?
Well, a natural cycle transfer involves getting the uterus ready using some endogenous hormones, so hormones that the body's producing by way of a follicle, just as if you were going to ovulate, and actually getting that follicle to ovulate, and then putting the embryo in after ovulation. The issue, though, is that the definition of a natural cycle, natural transfer cycle, really varies because you can supplement with exogenous estrogen or estrogen that we would give the patient either by patch or oral, vaginal, or by injection. You can also supplement with progesterone. We also typically, most places will try to time the transfer by doing a trigger shot so that ovulation is induced and we can time when we actually need to put the embryo in, because that's very important, putting the embryo in at the right time. So it's very rare to do a complete natural cycle where nothing is done except ovulating on their own, because the timing of the embryo, putting the embryo in, is off at that point.
And then there's really the question of why we would do a natural cycle versus a medicated one. And there's really pluses and minuses to both of these. And so for a long time, I think, and probably continues to be, but the kind of hormone replacement protocols that we utilize, what we're doing is we're suppressing the ovarian function, and then we're kind of taking over the cycle, building the lining to where we want it to be, and transferring the embryo at the right time. So this kind of cycle has a lot of advantages because we have very good control over the lining development, and we don't really have to worry about the patient ovulating and sort of how that's going to affect the lining. We've taken the ovaries out of that equation completely. And in so doing, it gives us a lot of control. It gives us the ability to plan for our patients so that they can also, according to their schedules, kind of do transfers, when it makes the most sense for them. But natural cycles have gotten more popular recently, especially because it seems like there may be a lower risk for certain types of pregnancy conditions with natural cycles. So things like preeclampsia may have lower rates. That being said, the literature suggests that natural cycle versus program hormone replacement cycles have very similar success rates with implantation and live birth. So it's a very important thing to keep in mind, but there may be some advantage, especially to patients who are already at risk for things like preeclampsia.
I think that we as a country, as a world, probably are trying to do things more naturally these days, and so natural cycles have really kind of taken off for that reason as well. One of the cons for a natural cycle is that you have to be monitored more commonly, so it's more work for the patient coming in, and also there's a higher cancellation risk because you may not have a follicle that is growing to ovulate, or you might have a follicle that tries to ovulate too soon before we're able to catch it and do the trigger ourselves. And so there is a higher cancellation rate. But as Dr. Carmone said, for when a patient receives a transfer, the success rates are the same with either a program cycle or a natural cycle.
And if I may add, there's an additional risk for cancellation. The natural cycle transfer may not be the best type of preparation for everybody, especially if your lining is not growing to an adequate thickness. And so if it stays in a manner that is not advantageous, it's not very thick, it's not trilaminar, a program cycle, if you can achieve that on a program cycle might be a better type of transfer for you.
Or if you have, I mean, the big one, irregular cycles. I mean,
Right.
you do not, if you have PCOS, which a lot of women have, then you don't have regular cycles, or you don't ovulate, then we can't really do a natural cycle. This is, you really have to take a little bit of a personalized approach when it comes to whether or not, natural cycle. There isn't really one right answer there.
Right. I mean, that you can do either one, programmed or natural, and they work for most patients as long as they're going to ovulate. But certainly, with you've been discussing it with your provider, you can talk about what works best for you.
What about the Natpro study? Should we kind of get into that right now? Is that
Sure,
something you
sure.
wanted to bring up?
Yeah,
Talk
sure.
about a little bit.
The Natpro study is a natural program. It's a natural program comparison of cycles, and it's a national randomized control trial. There's 20 centers across the country that are involved in this study. We're one of them. And so patients are randomized to either a natural cycle or a programmed cycle for transfer. And then during the course of up to 3 transfers, they stay in that group. And what we're trying to determine is exactly what Dr. Carmel mentioned earlier. Is there less risk for high blood pressure, hypertension, preeclampsia, implantation issues in the patients who undergo a natural cycle as opposed to a program cycle? There are some data that would suggest that that's the case, but the data are a lot of them are retrospective. It's not large enough to really get to find that there is real significant value. And so that's what this study is looking at right now. And so we are actually just beginning our part of the study, and we're starting to offer it to patients. Unfortunately, not every patient can be in the study. You have to, as Dr. Carmona just said, you have to ovulate. You have to have regular menstrual cycles and have a follicle that would ovulate in order to be included in a natural cycle. You can't have PCOS or irregular cycles. So there are some exclusion and inclusion criteria that we have to follow.
And one of the things that, I really didn't think about much of this is a sort of newer kind of thought process now is how exciting the corpus luteum is. So people might be wondering why a natural cycle may prevent certain things like preeclampsia. Well, I'm getting to that. So people might be wondering why a natural cycle may be better. I mean, if the lining achieves the appropriate thickness, who cares if we gave you estrogen or we didn't, or if it's at that thick. That's sort of the way that at least we've all kind of trained that it's really that thickness and appearance of the lining that matters, and not really necessarily the pathway that we got there with. But that doesn't necessarily seem to be the case, and the corpus luteum is the follicle within the ovary that's kind of ovulated. So when throughout a natural cycle, when women are starting the process of ovulation on their own, the egg lives in a little house of cells that support it. And as that follicle matures, that's where you can see on ultrasound that little kind of black circle, that little house gets bigger and bigger and bigger until it sort of bursts and releases the egg. After the egg is released, that house kind of luteinizes, it converts into something called the corpus luteum, which on ultrasound has the appearance of more of a hemorrhagic type of cyst. You can see kind of a blood collection there. And that's hormonally active. That's where we get the majority of our progesterone from. And so that corpus luteum then produces progesterone for another 2 weeks or so after ovulation. If that corpus luteum if you become pregnant, then that corpus luteum is rescued by HCG, by pregnancy hormone, and the corpus luteum continues to produce progesterone throughout pregnancy, really throughout for the first trimester at least. And so then, okay, well, we're giving the patient progesterone, so who cares, right? But that corpus luteum is not just producing progesterone. That, magical corpus luteum is producing all types of other growth hormones and factors and things like that that may be playing a role here. It doesn't seem to play a big role in the success necessarily of IVF, although there may be differences patient to patient. There's certainly people who seem to do better with natural cycles. But it really, those growth factors, may be playing a role in changing risks for certain pregnancy complications. And so really the big difference between natural cycle and, the hormone replacement protocols really is that there's a corpus luteum in natural cycles. We can still give estrogen and we can still give some progesterone and all that. But if there's a corpus luteum, that's kind of what we mean when we say that there's that the natural cycle has been completed.
Very good.
Okay.
I've never heard it referred to as a house.
Oh,
That's-
really?
that's
That's a
good.
house.
Yeah.
It lives in a house. A circle house.
Oh, yeah, circle, a
A
ball.
bubble.
Make me a
A
ball.
ball. It lives in a
Or
ball.
bubble. Yeah.
Okay, well, that was fun. So maybe we should talk about mini stem IVF, which is one of the things that I love to do. I don't know if anybody else loves to do it, but I do. I think it's great. So mini stem or natural cycle IVF, right, would be IVF using much lower doses of medication. And that's really it. I mean, that's really the definition. So, instead of utilizing more conventional doses, which for many women might include, a full sort of 300 units of FSH and another 150 units of HMG, right? Those are the Volstim and Gonal-F and Menopur medications you guys may have heard about. Instead of all that, we might so that'll be a total of 450 units of those injections, right? So instead of doing that, we would give 75 units of injections per day. Why would we do that? Okay, so the literature suggests that in most cases, if you're just comparing mini stem to traditional cycles, the traditional cycles have better success rates. So why do I, do mini stem on some of my patients? That's because to some degree, it is a little bit of a numbers game. And so there are many patients who I might give, 450 units of medication to per day, and they might get 2 eggs. And then I do another cycle and I do the same thing. I give them another 450 units per day and they might get another 2 eggs. Okay. Those same patients don't really need all that medication. If I give them 75 units, they might still get those 2 eggs. Okay. But it's going to be easier for them financially and perhaps in terms of side effects, depending on how they feel, to undergo multiple cycles. And so it may be more affordable and feasible for them to do mini stems and just do 75 units, mini stems 3 months in a row, and now they're going to have 2 eggs, now they're going to have 6 eggs, right? Versus if they had kind of, put all of their sort of emotional and financial resources into one pool and did a traditional cycle. They might, and just once, they're going to end up with those 2 eggs. So I think that the pricing is a big, big benefit for mini stem IVF. There are, the whether or not gonadotropins seem to harm gametes, seem to harm egg development or anything like that. I'm not sure that that's really been shown to be the case. I think really the benefit of the mini stems is more so how to kind of pool your resources and get the most sort of benefit to with your money and with your time. And so that's totally different than kind of the natural cycle transfer, but I think people are always wondering about differences between the mini stem and conventional.
People sometimes will call it just a natural cycle IVF, right? So the difference is with natural cycle IVF, it's completely a natural cycle without medications, and then mini stem is giving a little bit of medication with the IVF cycle. Dr. Glay, are there other reasons why you specifically would do mini stem cycles?
I traditionally like to do it after my patient has proven on a max stim cycle that they're only going to grow a limited number of eggs. And then at that point, with the numbers game, as Dr. Carmel was referring to, it becomes more financially feasible if we're going after only a handful of eggs and they're growing that handful with a much lower dose. Then that makes a lot more sense if we can do several cycles of that at a cheaper cost. But if your ovaries are capable of producing a more robust number on a higher dosing, I would recommend still going for the traditional IVF with the higher dosing rather than compromising the number of eggs you can get out. If you're capable of growing a dozen eggs, you shouldn't settle for a mini dose where we're only expecting a few eggs at a time.
Right, yeah. So, the benefit of IVF is getting as many eggs as possible. If you're only going to get one egg, it really doesn't matter how you get that egg. You got the same chance with that one egg. But if you can get 12 eggs from a normal stimulation IVF cycle, then that's what you want. I guess the con to what you're saying is there are patients though who will, with a max dose cycle, get 2 eggs, and then when you do a mini stim, their ovaries don't respond to, and so that's sometimes is the downside of that, and then you have to explain that to the patient. But certainly there are patients who with the max dose stimulation, their ovaries still don't respond either, and so you have to be aware. What about younger patients?
Yeah, so I'm pretty careful. I mean,
Younger patients are on kind of a mini stim already, but
right.
Certainly you could go lower.
You can go lower with younger patients, but the thing is you're going to get fewer eggs. And with older patients, that's okay because that's all you can get. But with a younger patient, that's tricky because, why get 5 eggs from someone if I can get 20? I mean, even in young people, the human reproduction, I feel like I say this at every visit, but human reproduction is just not very good. So, every egg has 7 to 10% chance for, yielding a baby. And so even in somebody who really doesn't have good fertility potential, or any infertility issues, they're not going to be able to have a baby with every single egg that we're getting. And so I would hesitate to really recommend a mini stim for a young patient. I mean, I think we can dose them appropriately, not necessarily, they don't have to have the max dosing of medication, but they also don't have to get, just 75 units a day or something.
Right. Try to optimize the number you can get.
Right. Safely,
Right.
So, I really do see it as more of a way to be able to have patients kind of do back-to-back cycles, and make it just more financially feasible and, cut side effects and things like that for them.
Right. And you can also, with the mini stim cycles, use oral medicines to augment the injectable medicines that you're giving to help lower the cost as well. We also will use that for our max stim protocols as well, but it doesn't have quite the same effect as you get with the mini stim patients. And certainly with mini stim, you can just use oral meds too, depending on what how many follicles they have.
Right. Yeah, and I suppose that the cause of infertility makes a difference too. I mean, if you're sure that this is a tubal factor, because if this is somebody who has had a tubal ligation and they never had any fertility issues and they're young, then using lower doses of medication in a patient like that is perhaps more appropriate than somebody who has unexplained infertility. Even if their ovarian reserve numbers look good and all that, there's a fair proportion of patients with unexplained infertility probably have a subtle egg quality issue that we're just not really picking up on. And so they may need as many eggs as we can get to be able to overcome that problem. So I think you guys will hopefully be hearing a lot more about the Natpro study from us and our marketing efforts to try to kind of get the word out about the Natpro study. So definitely kind of ask us questions about that, see if you're a good candidate, and help us answer this question of whether or not the corpus luteum really matters, whether or not it's as magical as I hope it is. I've been telling patients it's super magical, so I'm hoping that that the study kind of really answers that question.
I think that the reality is with pretty much with all studies that you typically will, you may find some difference, but typically it's not a huge difference for the individual patient,
Right.
and it's not till you're looking at 100 or 1,000 patients that you get, a benefit of 1 to 2. So the question is, are you going to be that 1 to 2? And certainly when we look at population, we would like to decrease any kind of risk by 5 to 10% if there is a way to do that. And so that's what we're always looking for, while still maintaining the success rates. And that's the nice thing, is that the success rates are the same regardless of how you do it. It's just just want to find out if it's better for the patient during their obstetrical journey.
Right. Okay, well, it was really nice to have you in our office today here instead of
me in
being
trapped me.
So thanks everyone for joining us today. This is Ask the Docs, a Fertility Institute Hawaii live stream. And for more information, definitely check out our website, ivfcenterhawaii.com. If you have any additional questions, feel free to leave comments here and then we can answer them later. Or of course, give us a call and schedule your consultation now. Okay, thank you. Aloha.
Bye.